lidocaine injection for migraine treatments. So this is a 21-year-old female patient who has intractable migraines, has failed all different types of conservative treatments, including Botox management, and so we decided to do a lidocaine injection, and we are classically going bilaterally into the MMA, and so here's with my Bernstein catheter trying to find the MMA, or trying to actually find the common. So what do I do next? I retracted the catheter, maybe there was not enough flow. It's still no common. So I retract even further. What's going on? Exactly. So we have here an aberrant subclavian. So this is what it looks like when you're trying to go up. You think you are, especially in these young patients where you have very straight vessels, you think you are in the brachiocephalic trunk, and you're just like flabbergasted, as I was actually at the beginning, to see that there's no common there. And then when you go back again, you see that this is where the aortic arch is, right there. So you have to point your catheter now to the side here and go around like this, and then you will be able to find actually the aortic arch. So it's just something, not in every single case that we are doing do we have a preoperative CTA. In most of my patients, I do have a preoperative CTA. In these young patients, for radiation purposes, I do not do these. So keep this in mind that this is a trap. This is how it would look like. Think about this variation that can be present. Okay, that was an easy warm-up case. Now we're getting a bit more complex. So first of all, what does this patient have? That's the easy question. What is the diagnosis? Dural arteriovenous fistula. Okay? Okay. Is this something we need to treat? Yes or no? Yes. Of course, because we have corticovenous reflux. Good. Now, which vessels are feeding this dural arteriovenous fistula? Obviously, we have vessels coming from the ICA and we have vessels coming from the ECA. What is the vessel that is coming from the ICA, and do you see any variation of normal here? And what will it tell you? Sorry? So there's a dorsophalmic here, very good, which as Insu told you, is kind of like the remnant of the ILT, which will help you to understand the anatomy here. So which vessel is, let's say here, this one? That's the middle artery, exactly. So the fistulous point is right here, right? There's the draining vein. We see that the same fistulous point is here. So what are the feeding arteries here, and how do they connect through this area here? So for this we need to go into the anastomotic channels that you referred to today about the cavernous sinus and the paracavernous sinus region. And there are different ways to visualize these. I think that what Insu will show tomorrow is the most elegant way. One other way to look at it is this way from the diagram of James Byrne. So we see here the middle meningeal artery, and it can anastomose at the level of the cavernous sinus to cavernous branches. You can also see that we'll have from the artery of the foramen rotundum an anastomosis, and you can see that from the recurrent meningeal artery of the ophthalmic artery, we can also have vessels getting into the same region. So what we are facing here is therefore middle meningeal artery with cavernous branches interconnected to the branches from the IRT remnant, which is the dorsal ophthalmic, and from the recurrent meningeal artery coming here towards the region of the SOV where the fistula is located. given these anastomoses, is this a safe artery to embolize from an arterial perspective? First of all, can you treat this patient with glue? Or why is glue less likely to work here? It's a lower question. Exactly, very good. So we have here not a relatively large area of blood supply, more or less like even looks like a nidus within the dura, right? And it has supply from both sides. And in the moment where glue, that you have to, when you prep your microcatheter, you have to inject glucose. And if the glue reaches towards blood that is unglucosed, it will harden. And because there's flow coming from two directions here, it's virtually impossible to penetrate deep enough into the vein. Therefore, your glue will likely stop. So therefore, you will have to think about in these types of cases on onyx injection. This looks like a pretty juicy vessel here, no? You can easily get your septum mini up there and onyx the hell out of it, right? Or why not? The safety margin with the ophthalmic, therefore towards the ICA. You will reflux at one point in time into the ophthalmic, and then you have your onyx in the ICA. That's not a good place to have your onyx. So therefore, what would be the way better treatment, way safer treatment in this patient? It's a transvenous case, exactly. Because you can see that this is a pretty straight route. And with the triaxial system, where you can park one catheter all the way here, it used dual catheter technique with retrograde pressure cooker technique will do the trick. However, with this technique too, you should not over-inject, and you need to know where your security margin is, because at one point in time, whether you go transarterial or transvenous, you will reach. Remember the picture that Vincent Joel showed you where he did the pressured injection in the cavernous sinus. At one point in time, you will reach also from a transvenous perspective in the arterial side, that you can reflux back into the ophthalmic artery here. So here you can see our triaxial approach with the retrograde pressure cooker. Here are some coils, a couple of coils here, and then the injection. You will have to fill the entire network and ensure that you have a projection that allows you to see where the recurrent, where the dorsal ophthalmic, persistent dorsal ophthalmic artery is. And this is the 3 months control in the patient with the complete cure of the fistula.
Can only coiling work if you are able to reach, since it's safer?
Safer if you are able to reach the fistula's point, can only coiling work? Because there will be no chance of reflux to the arterial side.
Good point. So you can actually go into the recurrent ophthalmic, start coiling there, and then inject from the other artery. So that's also an option. However, then there's a risk for compromise of like the orbital component.
So what I meant is transvenous coiling.
Transvenous coiling
without equally work.
You could give it a try, but it will take some time until it completely occludes. I would use in these cases more fibered coils, and because we are in a pilot vessel, these are stiffer coils, and I would be a little bit worried. One option would be coils, and then glue, because glue is thrombogenic and even a little bit will help you. In this case here we used onyx, knowing when we had to stop. Okay, here's another case, very similar. So we did also here already the solution, the transvenous approach in this case. Here with a very similar type of approach, where we went through the cortical vein here, did a retrograde pressure cooker technique, where we see mainly coils and then a little bit of onyx in here. But I would like to tell you to tell me what are the feeding arteries here and what are the risks. So first of all, is this a normal ophthalmic artery, or do we have variant ophthalmic artery here? There's the origin of the ophthalmic right there. What a trick question. Sorry? That's a normal ophthalmic artery, correct? And so, how do we have this fistula now being filled? Why do we have filling from the ophthalmic artery? Which vessel is going back towards here, the fistulous point? That would be again the recurrent meningeal artery, exactly. And then which vessel do we have coming here from the distal imax going up? And again, remember this type of connection here that would be an infraorbital artery or the artery of the foramen rotundum. It can go back towards the recurrent meningeal artery. So therefore, know your anatomy, and if you're not sure about your anatomy, it does make sense to not do the treatment at the day of where you're performing your diagnostic angio. If you're not sure about the anatomy, bring the patient back, only do a diagnostic angio, really learn the anatomy, and know where your security margins are, and then go for treatment. Okay. So that is the wrong picture. Okay. Okay. So here we have the next patient. And again, first question, what type of vascular disease are we facing here? We will hear more about this later, of course. This is again, what? Dural arterial fistula of the cavernous sinus, yes. Do we need to treat this patient?
Yes.
Why?
Cortical vein, posterior fossa veins.
Okay, where, and we will hear more about the venous anatomy later, but just very briefly, how can the cavernous sinus drain towards the posterior fossa? Which conduit?
Basal vein.
Uncle vein going to basal vein going down, exactly. So that here is the uncle vein going down towards the basal vein of Rosenthal, then going into the posterior fossa veins. And why is this dural arterial fistula not going where it used to go, like into the superior ophthalmic vein, inferior ophthalmic vein? Because these channels over time can thrombose. Okay? And that's actually the natural history of these dural arterial fistulas, that some of the outlets over time close off. And again, we are going a little bit ahead of us because dural arterial fistula will be the topic of Wednesday. But what are the feeding vessels that we can see here? Let's start off with the injection here into the external. We have a vessel that is coming off the imax here that is going up and then reaching the fistula here. What is this vessel? That would be accessory meningeal. Okay, and then we have here other vessels that are coming off from the distality. This would be artery of the foramen rotundum or artery of the foramen ovale, that all converge towards the fistulous point that is present in this region here. And how is this fistula filled from the ICA? If it's artery of the foramen rotundum, and we've learned today exactly that this is the IRT. So again, look at your anatomy and try to identify which one, which vessel today. How would you treat this patient?
Transvenous.
How would you treat transvenous? Through the pile veins?
IPS.
Through the IPS. In order to treat through the IPS, you need to, however, know whether the IPS that is clearly not visualized here is anatomically present or not. Because you can have variations where you don't have an IPS. So what I like to look at in these cases is therefore in my CT to have a look at whether we see like a notch where the IPS would have been. So the approach through non-visualized venous segments has to have a certain intellectual component to it, because reasons for non-visualizations can be thrombotic occlusion, in which case you can go there. You can have anatomic variations, true absence of a visualized segment, or functional cause that the venous segment is used to drain normal drain, not the shunt, and therefore you are just not seeing the opacification. So what we are doing in these cases is we are looking at the CT. In this case here, of the right-sided fistula, you see that there's a clear IPS there that is being filled, but on the side where the fistula is, you see a small notch where you would expect the IPS to be, but there's non-visualization, which means that the IPS that should be there is thrombosed. And this means that you will be able to get through this occluded segment. The way that we are doing it, there are two ways. In general, here you can also see nicely the IPS on a slightly higher slice here being opacified. On the other side, it's not opacified. There's the dural arteriovenous fistula in the posterior compartment of the cavernous sinus. We first inject the jugular. Sometimes you can see a small sliver of the IPS, then you can hook your catheter in there. But if you don't see it, then I like to use a triaxial system. We know from the anatomy that the catheter has to point anteriorly and medially. So you use an arterial roadmap that will show you where your target is, i.e. the cavernous sinus. I like to wedge the guide catheter into the IPS, and you will hear more of this also from Insub. You either use a microcatheter with a microwire or a glide wire, rotate it, slowly advance, and then make a channel through which you can then take your microcatheter up. And once you are in the abnormal segment, you remember here the uncal vein. I go into the origin of the uncal vein, do a pretty dense coiling there to occlude the reflux, thus filling the fistula. Here's the final coil mass, and the patient's fistula can be cured. And this is something that we wrote up with Sientara's group a couple of years ago, which I think is still a very valid technique for these types of dural arteriovenous shunts. Okay, I think that's it from my perspective. Any questions?